So welcome, 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 and thank you all for joining us on our third season of the Bouncebacks Critical Care Book Club. And this is chapter 16, so we are just barely, now like 20 seconds, halfway through the book. And we have taken a break over the summer, and welcome back to a really, really fantastic panel and a fantastic case. And I'll introduce folks in just half a second here. But the case that we're talking about today is important because certainly we have a differential for patients who are confused, but we also have a different differential for patients who are confused and with a headache, confused and with a fever, or confused and with a history of end-stage renal disease on dialysis, which is what our patient that we're going to be talking about today is. So this is chapter 16. It's a whole new section, and we have 6 different sections of the book, and I'll introduce in just half a sec Mike Winters, who's our section editor for that section. So let me pull up our PowerPoint here. Just a couple quick disclaimers. We are recording this, and if anyone wants to watch later, they can also watch the previous 15 episodes. There were a couple we had some technical difficulties on, but that's on the EM Bounceback, so like emergency medicine Bouncebacks, embouncebacks.com. You can sign up for other programs of our Bounceback book clubs. You can see the past fantastic experts that we've had, and we've really had the best of the best top, and not only just emergency medicine, but specialty faculty around the country on the first 15 of these. So just in way of disclosing, there are no financial disclosures, and I'll leave this up here for just a second. Towards the end, and also we'll flash the beginning, there's a QR code for folks to get CME, and you get 1 hour of free CME for joining here. I want to also make sure everyone knows that this is a group discussion. In the past, we've had such amazing amount of knowledge with not only the faculty, but also everyone that's participating. So we want to hear from you. If you have questions for our expert panel, love to have you put those in the chat, and I will be monitoring that. So here's the QR code to claim CME credit. If you want to take a quick picture of that, you can get 1 hour of free CME credit. And there'll be this flashback up towards the end also. So here's our panel, and this is Greg Eisinger. He is assistant professor of medicine, pulmonary critical care and emergency medicine at The Ohio State University. And also Dan Martin, who we've worked together for many years, is also from The Ohio State University in emergency medicine and vice chair of education and a professor. Cody McCoy is a internal medicine resident, although I will say Cody, internal medicine resident extraordinaire as well. Cody got married on Saturday, and he's here. I mean, the dedication that this guy has towards medical education cannot be surpassed. Canceled his honeymoon so he could be here for the the critical care Bouncebacks book club here. So thank you, Cody, for that. I'm not sure your wife has as much thanks as we do for that. Kevin Pargeter is a board certified nephrologist, and so obviously nice opportunity to get his incredible amount of expertise on things. And then Mike Winters, who is the section editor for this section, and he is a professor of emergency medicine at University of Maryland and expertise in both emergency medicine and critical care. And again, I am super humbled by the fact that you all took this time to be with us tonight, as well as folks that are participating and folks that'll watch this later. So we're going to be talking about a 52-year-old woman with end-stage renal disease who has confusion. And we're going to start a little bit earlier with her first visit. So this is a patient that presented just after noon, and this is the actual documentation. Nothing has been changed for HIPAA reasons. Obviously, there's no names or patient identifiers here, but all this is the actual documentation. I just highlighted the important stuff to bring out, and we're going to talk about the initial visit sort of briefly, but the whole focus of this critical care Bouncebacks book, which is why this is different than the first 3 books, is because what we do is we really concentrate on the return visit, and we reach different decision points. We then think about different clinical questions and answer those in a literature-based fashion, find out what happened to the patient based on what the actual physician did, and then we go to another decision point. And we sort of work our way all the way through the patient's care in the emergency department, sort of if you were in the footsteps with a expert whisperer whispering in your ear. So this is a patient, as we said, 52-year-old woman. She presented to the emergency department with severe, constant mid-abdominal aching sensation without radiation. Started the morning of her presentation, no change with food. She has had identical pain in the past. Denies any fever, vomiting, diarrhea, blood in the urine or stool, urinary symptoms, vaginal bleeding, discharge, etc. Last dialysis was 2 days ago. The next one is scheduled for the day after. Now, on her past medical history, not that surprising, in addition to end-stage renal disease, she also has diabetes. She also has a history of gastroparesis, and her vital signs are essentially normal, some very mild tachycardia, and her abdominal exam shows a non-distended abdomen, mild to moderate pain with palpation, but soft without rigidity, rebound, or guarding. So I'm going to start things off here and throw the first question out to Cody McCoy. And this is a long differential for abdominal pain. But Cody, I thought if you could just sort of detail for us the way that you would work through a differential for not just abdominal pain in the ED, but abdominal pain in patients with end-stage renal disease.
Absolutely, and thank you for the very kind words in the introduction. I do want to clarify before anybody thinks I'm a monster that I, canceled the honeymoon. The current residency schedule, that's what's delayed the honeymoon, but I'm very excited to be here, and thank you very much for including me. It is a very
right.
long list of differentials. We always got to think about acute coronary syndrome. Anytime we hear abdominal pain, there's all sorts of presentations to the ED that people miss because they're just thinking about that classical chest pain. But also, one thing that is very important to think about in end-stage kidney disease would be thrombotic complications of that. And depending on how somebody ended up with end-stage kidney disease, be it nephrotic syndrome, those patients are going to be at an increased risk of being in a prothrombotic state. They lose albumin, things like that through the kidney, but they also lose antithrombin 3. So thinking about things like mesenteric ischemia, and then some of our other etiologies that we would think about in anybody else, pneumonia, it's presenting with irritation of the diaphragm. Is this patient, here we know they're an HD patient, but say they're a peritoneal dialysis patient. In that case, they could be having a secondary bacterial peritonitis as well. Have there been any surgeries very recently? Another very important thing to think about. Urinary tract infection is another one that can cause abdominal pain, something similar to an ACS where we don't think about that classical place where it's going to present with pain. And then is the patient fluid overloaded? That's a few of the things I would be thinking about if they came into the emergency department.
Gotcha. And so, Kevin, I wanted to sort of throw this out to you as the nephrologist on the call, because this always tricks me up. I mean, in the ED, certainly with abdominal pain, just about always check that urine box. But in patients that are gangrenic, you would think that maybe even they just have a small amount of urine sitting in there, it could cause infection. But literally, I'm struggling to think of any time that I've had a patient with dialysis who's actually had a urinary tract infection. I mean, how do you navigate that in a patient either who is anuric or oliguric?
Well, it is true. Are you guys? I thought I'd test my audio one more time. Is it coming through?
We can hear you.
Great. Well, it is true. It is true that asymptomatic pyuria, meaning those white blood cells, we'll commonly see them on a urinalysis in a patient who's hardly making urine. We'll find that they're from that urinary stasis. They're essentially oliguric or anuric. That urine sits there in the bladder, urinary stasis. So the urinalysis might have quite a bit of sterile pyuria that is culture negative. And so it's hard to trust that urinalysis. So this is where the art of medicine comes in, that if they are having suprapubic pain, in this patient it was more mid-abdominal pain, but suprapubic, they may have fevers, but they probably won't have dysuria because they're just not urinating. So it's hard to go off of those urinalyses. But if we do a thorough workup and they are feverish, they are having also a leukocytosis with no other etiologies, well, then we might make that diagnosis of UTI in an ESKD patient, end-stage kidney disease patient. But I was reviewing the literature on this. Even in 2020, the prevalence and clinical characteristics of asymptomatic pyuria in advanced kidney disease, that was in the Annals of Laboratory Medicine. The vast majority, high prevalence of asymptomatic pyuria, especially with increasing stages of kidney disease, in this case end-stage renal disease. We're going to see it, but it's probably not going to be a true UTI.
Well, I'm glad you said that in sort of in some ways, like a patient who has a indwelling Foley catheter, right? If they don't have back pain or fever, I mean, they're all going to have a bunch of white cells in the urine. So, Greg, let's sort of move to you, obviously EM and pulmonary critical care. So, how would you start the workup for this patient? It's a patient with abdominal pain. She said it's identical to what she's had in the past. It's mid-abdominal pain. What labs would you order? Would you go for imaging, or are you going to trust a little bit more your clinical exam?
Sure. Yeah. So, I think obviously with any of the testing that we're going to order in the emergency department, it's going to be directed by our differential, right? So as Cody laid out, those are the things that we're thinking about here. And, you try not to be too much a sort of Monday morning quarterback on these cases and think about, well, what I really done, not knowing that this is a Bouncebacks critical care case, which obviously frames things a little bit differently. The
Right.
HPI here alludes to the fact that this is a patient who presents very frequently with abdominal pain like this. She has a history of gastroparesis, and it'd be really easy to anchor onto that. Nonetheless, she's at high risk for a number of complications, vascular complications, metabolic complications, infectious complications, as we mentioned. And so I think most of us are going to go ahead and at least order a panel of basic labs on her. So, we rattle off, we're going to get belly labs. We're going to grab a CBC to look for, has the patient become anemic? Does the patient have a leukocytosis to suggest an infectious process? We're going to grab that chemistry too. Obviously, we don't care a whole lot about what the creatinine says on there, but what is the potassium? What is the bicarbonate? What is the BUN compared to her baseline? What's her glucose? Those kind of things. Of course, the LFTs we're going to need to tell us if there's, a hepatitis, another biliary process that could be going on, explaining her pain, cholangitis, cholecystitis. We're going to grab that lipase to look for pancreatitis. Cody also mentioned this patient's probably going to get a troponin. I mean, we could probably spend an hour talking about whether she should and kind of what the reasons for doing that might be, and especially in a population where we know that they tend to have a elevated troponin level just because the renal clearance of that enzyme, and especially now with our the generation of high sensitivity troponins. You may be asking a question you don't want the answer to when you order that, but I think it's a reasonable thing to do. And of course, you have to take that in the setting of what's the patient's baseline, what's the EKG, what are the symptoms looking like, and things like that. We talked about the urine.
Yep.
And so just really quickly then, obviously I think the last things we're going to talk about here are the lactate to screen for some sort of ischemic process, with the understanding that the sensitivity is only about 85% of the serum lactate for bowel ischemia. And then the real question is going to be to scan or not to scan, and if so, what kind of CT to get.
Okay, so I'm going to come back to you in a second. So you maybe don't need some time to think about it, but if you want some time to think about it, we'll ask everyone that question here in just a second. So Dan, I hadn't really intended to go here, but it's sort of an interesting question about this troponin. Certainly with epigastric pain, we'd be thinking if there's some sort of inferior myocardial ischemia. Of course, she has diabetes, so maybe there's a neuropathy and she's presenting a little bit differently than a person that doesn't have diabetes would present based on the ACS that we're considering. But Dan, I assume that you're getting these labs also. Are you including a troponin in your initial test, Dan, considering the fact that very possibly it's going to come back at, 0.04, 0.05, like minimally elevated?
I'm a little overly cautious. I think I'm probably getting that test as well as an EKG on these patients just because of the risk that they can have something with very minimal symptoms. Hyperkalemia itself, if you look up all the symptoms you can get, abdominal pain is even described because of that. So, I mean, I think this patient is very high risk. Now, I would say this. If this person gets better, if I look and see what they were treated with before, I could probably defend not necessarily getting a CAT scan right off the bat on this one, but at least a good screen to make sure they're not infected, as Greg mentioned. I think I'm doing all those things, and I totally agree. I probably would get a chest X-ray. I don't see, in fact, they describe the patient's abdominal exam as not being distended. And it doesn't sound like it's rebound, it's acute, it's not localizing to one of the really bad infection areas. I will say one thing. I have a hard time not getting a chemistry on almost anybody who's in and out of AKI and who's a renal failure patient. I don't care if they have a sprained ankle. I'm going to have a hard time not getting a chem summary. That's probably just me. But I've just seen too many M&M cases where the patient has a visit, nobody went into much depth on their history, they were in for another reason, and they came back really sick in a day or two. So with that varying creatinine, the way that can change and the potassiums can in this population, man, I think I'm getting chemistry with a pretty low threshold. Just to
Gotcha.
put that
Okay,
out there.
so perfect. So Mike, bring it all home for us here. We're always trying to balance, right? Everything we do, right? I talk about the 3 S's in the emergency department, patient safety, speed, satisfaction, right? The 3 S's. But in the same way, we're also trying to balance the risk of missing serious disease with the risk of false positives with overtesting, right? So give us some thoughts, and I'd be interested in your thought on troponin as well as your thought on advanced imaging with this patient. And that, don't think of it as a bounce back patient. Just think about it as your average patient, mid-abdominal pain, doesn't sound like there's physical exam, surgical abdominal findings, and she has had identical pain in the past. And while we're doing that, I'm going to pull up her labs here so you guys can take a peek at those.
Thanks, Mike, for the opportunity to comment. And as a general rule, those that work with me, especially our residents and fellows, know that to coin a phrase by one of my colleagues you all know very well, Dr. Matu, I personally tried to be more of a sniper with labs and imaging rather than a shotgun approach. And wearing my hat from a clinical affairs standpoint and also thinking about ED operations, as you just mentioned, Mike, every test, whether it's lab or whether it's imaging, comes at a cost. Sure, there's a financial cost involved in that, but it comes at a cost of potential adverse events with the patient. It also comes at a cost of prolonging turnaround times, prolonging ED throughput. So I do not like, as a general rule, shotgunning labs, obtaining a lot of things because I know that's going to lengthen my ED throughput. And I really want to specifically obtain a test that is going to help me answer a specific question for that patient. Now, having said that high level 40,000 foot approach to just ordering labs and diagnostic imaging, I'm going to lean back to something that Greg said and that anchoring bias on gastroparesis from the first visit. For me, as you were presenting the HPI, Mike, I heard abdominal pain, but I didn't hear vomiting. In fact, there was no vomiting. And something is atypical in the presentation of this patient. The fact that you heard others such as Dan talk about end-stage renal disease and just how predisposed they are to a number of serious conditions. And the way the exam is written, where there's a 9 out of 10 abdominal pain, but the way the charting is with respect to the abdominal exam, to me is pulling out a pain out of proportion. So when I'm approaching this patient's in front of me, I am going to do more with respect to labs along with imaging. It's okay. I think it's reasonable to do troponin. I don't know that I would jump right at it and send it right away. I'd certainly look at her other comorbidities, look at the exam, look at a 12-lead EKG. Is it likely? Sure. But I don't think I would be cluing in on that at the onset. I would be concerned about that pain out of proportion. So I do feel that in this particular person, I'd probably order the imaging early, considering some of that differential that Cody went through, namely mesenteric ischemia.
Gotcha. And so, Mike, let me give you a follow-up question here. You're getting, I'm guessing, if you're thinking about that, the CTA abdomen pelvis. Would that be true?
Yeah.
Do you have any reluctance to do a contrast study in a patient with end-stage renal disease?
No.
And Kevin, is he right?
Well, I love this question. There's a long-standing dogma of wanting to have the nephrologist dialyze the patient right after contrast enhanced imaging, but that's not the case, especially in the longer vintage dialysis patient, especially where they're essentially anuric and no residual kidney function. It is an acceptable option, and we're talking contrast with CTs, of course, different topic with gadolinium, right? But back to the contrast CTA, it is okay. And I even, at Adena Regional, where I practice, we now use EPIC, part of the Community Connect approach, which means we use the Ohio State software. We kind of subscribe to their software. So I was able to review the OSU Wexner Medical Center clinical practice guidelines on this topic. And even as of December of 2022, it is accurately stating no routine dialysis should be added on after a contrast CTA. It is okay to proceed like normal.
And Mike, I'm sure that with some of the work that you do at University of Maryland and quality review, I mean, I've had that same situation where a patient will come back and someone was reluctant to use contrast, or they delayed the contrast administration. And this is a little bit different story, but just they were concerned about renal function, for example. So the American College of Radiology 2022 guidelines say you don't need contrast in your average patient below 50 without hypertension, diabetes. But we all know that also with patients with end-stage renal disease, yeah, we shouldn't have any reluctance at all. And it is still funny to me how the tech will come up and say, well, are they going to be dialyzed within 12 hours or whatever, because this huge amount of fluid they're getting, which is probably like drinking a Coca-Cola, can of Coke. But anyway, maybe it's more than that, Kevin. I don't know. But I mean, I guess my point is just the same as what we're all saying, that I would not have any hesitation to do that. So let me just real briefly, just a yes or no answer. And Greg, would you get imaging on this patient, assuming that the labs came back okay? Or would you be comfortable sending the patient home based on your clinical exam? And I'll just do because we want to move on and don't miss out on the other stuff. So imaging, I guess, yes or no?
Yes, unless they've had 10 scans in the last 6 months, which is always a possibility with a patient like this.
Right. And I didn't really share that part. I don't have that information right now. So that's an important thing to do. Dan, imaging at this point, yes or no?
More yes than no.
Okay. All right. Fair enough. And Cody, what do you think? Yes or no?
Yes, I believe so.
Okay, perfect. All right. So here's what we're going to do. We're going to tell you what happened. And this is where sort of I guess in medicine, we'd say sort of fun in quotation marks starts as far as the critical care aspects of things. So the patient is sent home, and in no way am I saying that that was wrong or bad or that it should have been done, but this is just what happened, because I think there's room for discussion on that. Again, the patient has that identical pain. I'm guessing probably has that imaging in the past. We just don't have that information. So everyone obviously gets individualized, of course, in context of the patient's specific presentation. But at any rate, 2 days later at 9 o'clock in the morning, the patient returns and they say EMS say the family found her responsive in bed this morning. So there's not any sort of last known normal beyond the night before, as far as the fact that she had woken up that morning. They went to check on her, wasn't able to be aroused. She did say she didn't feel well yesterday, but again, I'm just reading exactly the documentation as it came out. So this is really what we know. And she was supposed to be at dialysis the day before, but she did not go. So you remember, we saw her, and then she was supposed to be dialyzed the next day. The previous had been 2 days before, right? So EMS checked her blood sugar, and it was low. They weren't able to start an IV line, and her blood pressure is 70 palp. Obviously, she's unable to give any history. And here we see her emergency department vital signs. So she's afebrile, heart rate 117, respiration's 12. That's not good. Blood pressure is 60 over 40. Her sat on 4 liters is 91%. And this is a person who does not use home oxygen, and she's unresponsive to verbal or painful stimuli. So, Mike, I wanted to just start it off right from scratch. You are now our expert whisperer. And if I'm seeing this patient, you would definitely be the guy I'd want to have behind me whispering in my ear. Where do we start? I mean, we can check a whole bunch of boxes, right? If we're sitting at the computer, but we're at the bedside now. We have all different kinds of potential things that we could be doing, asking people to do different things. Where do you start as far as prioritizing your evaluation?
Well, I have to say, Mike, these are the patients that I love to take care of in terms of
Yes.
resuscitation. I think all of us probably do, with respect to them, how this person is presenting. And you're right, we could go immediately for a lot of things. We could try to replete the glucose, look at that Y complex, tachycardia, interpret it. And I think probably years ago, the way that she is presenting with unresponsive to verbal and painful stimuli, we would jump right to securing an advanced airway and endotracheal intubation. And we've learned over the years, and there's lots of mantras, that pushing to quickly intubate this person and administer RSI drugs, if you're going to do that, can really turn this into not only a critically ill patient, but a cardiac arrest quite quickly. And I think that we've moved towards really focusing in on the circulation. So lots of things to do for her, but we really got to get moving on resuscitating her circulatory system and bringing up that mean arterial perfusion pressure. So we start to then get into the other interventions and can do them a little bit more safely. But really, we got to focus first on circulation.
So let me give you a follow-up question on that. So the paramedics were unable to start an IV line. We know she needs at least two things. One is an amputee 50, and the other thing is certainly at least some fluids. And maybe if she had that abdominal pain, decreased PO input, gastroparesis, whatever, maybe it is more of a volume type of thing, possibly, right? But we don't really know for sure. So Mike, where do you go as far as vascular access at this time?
So
If they're unable to start an IV with the first attempt, say it's 2-3 minutes, there are a couple of people trying on each arm. I'm sure you've been there. We all have.
Yep, and our nursing colleagues will continue to try and establish peripheral IV access while we're moving. But given how critical this person is in peri, and really moribund in peri arrest, I think all of us would move towards an IO to get quick access to deliver, whether that be the glucose, maybe start to push a little bit on the fluid, but get some labs, give glucose, and then start to resuscitate. Now, in terms of location, I think we're very familiar with the proximal tibia. There's lots of different locations you can go for IO access. It may be a little bit more challenging in the proximal humerus, but I think the limited literature I've looked at, quite honestly, I've moved a little bit more towards proximal humerus just because of the amount that can be infused a little bit more quickly, and things can reach the central circulation a little bit more quickly than, say, the proximal tibia. Is there a robust amount of evidence behind that? No, but I'm going, the big thing is IO access to get started while we'll look for other vascular access.
Yeah, and I just want to also highlight something else you said about this resuscitation before intubation. In the study by Hefner, this was 2016, I think, and they looked at patients who were hypotensive, who had a peri-intubation arrest, and found an 82% mortality with those patients. So super important, obviously, if we're able to get that get that line established, at least do some amount of resuscitation before this intubation. That's something that really would make a huge difference. So Dan, I'm interested in your thoughts on IV access, vascular access, I should say, as well. And then we'll ask Kevin about that. So Dan, if you want to just give us sort of a short sort of thought, you're with the residents, they're maybe not freaking out, but you're concerned, appropriately concerned. What do you direct everyone to do at this point as far as getting vascular access?
I like Mike's idea of simultaneously getting the nurses started on each arm, either someplace in the antecubital fossa or above for upper extremity access. I think though, boy, I tried to look this up and every study I saw is the same. And that is the success rate with IO is better than a central line. The rapidity is better. It's 2 or 3 minutes compared to 8 to 10, depending on who you read. So I think IO, I totally agree that's the way to go. You could argue that you get higher flows with CVC. I think you get great flows with IOs. Only exception might be using a cordis, but I don't think you need flows that much anyway to get this thing going. The only other possibility is if everything is really fumbling around and this person has a dialysis catheter, it might be a way to get blood work or give calcium or one of those things. I'm just putting it out there. Not the optimal, and you want to do it sterilely, but that's a possibility.
So Kevin, I see you smiling, and that means you have something important to say.
Yes, well, so there's been a long-standing teaching that we always even start with medical students and lab techs is never touch that tunnel dialysis catheter. But in a patient rapidly dying before your eyes, in your chapter even referenced the Journal of Emergency Nursing 2008 by Manning. So I reviewed it, and it had 4 key questions. Is there active CPR imminently? Are there vital signs crashing? Is the EKG so severe, like widening QRS? And if the patient is more likely to survive with better outcomes by accessing that dialysis catheter, and if the answers are yes and there's been no other successful line placed, well, then it would be okay, because if you can save that patient's life, and if it can be done as sterilely as possible, it's probably going to have more benefits than risks. And if I may, I think this would be a great time to do a little bit more education on dialysis catheters. And so they're actually not in the subclavian. These tunnel dialysis catheters are tunneled over the clavicle into the base of the internal jugular vein. But even just this weekend, I had an ER. He was actually, I'm not sure if he was ER, emergency medicine, in a small rural hospital, page me about the subclavian dialysis catheter. And I'm thinking to myself, that's actually a tunneled IJ dialysis catheter. But nevertheless, so that's one thing I wanted to teach. The other is how to access it, because there's this long-standing teaching, never touch it. Well, if you did need it, how might you do it? So let's go over that briefly. First we would use chlorhexidine. We're going to clean. There's two ports. There's a blue and a red. And so we're cleaning those exit sites. Those caps are then taken off. And then if you want to pull blood, you're using the venous limb, pulling it away from the patient. And then you clean and recap it. If you want to infuse calcium or other drips, you would use the arterial limits, returning it back to the heart. And then you would want to connect those limbs as promptly as possible. But before you do, you always want to aspirate whatever that locking solution is. Heparin is common. It may be falling out of fashion. There's citrate, and there's also normal saline. You know, speaking of OSU Wexner Medical Center's clinical practice guidelines, right at the top of their heading, even today, is an update bulletin. No more Hep locks. It's all going to saline lock at Ohio State University. But nevertheless, so you aspirate, we try to flush with sterile saline, and then you connect your solution. So it's only used for absolute emergencies.
So a couple comments here, and I'm going to bring those out in just half a second. Greg, I'm going to ask you to sort of weigh in next, because I said that we had a couple problems. One was the hypoglycemia, the other was the hypotension, but we also now have this wide complex tachycardia that we've started talking about. So I'm just going to read quickly David's comments. Unfortunately, I've done RSA way too soon in the early 2020s, before the resuscitate, before intubate mantra was well known and emphasized. And he says, further, I'm concerned for possible hyperkalemia. I'd push calcium chloride and insulin and possibly albuterol 20 milligrams. So not just the 3 milligrams, but the 20. David, thank you for that higher dose there, via the endotracheal tube, norepi for the hypotension. So Greg, why don't, if you could, first just sort of concentrate on this wide complex tachycardia. Assume now that we do have a line, say it's an interosseous line, just for example, where are you going with addressing this wide complex tachycardia? Are you waiting for labs, or are you starting right away with medications?
Yes, thank you for the comment, David. I think that's it's hard to hear these cases and not be hearing those things happening, right? You're like the resident or the physician in you is getting uncomfortable as we continue to talk with this unstable patient in front of us. So yeah, absolutely. I mean, I think about wide complex tachycardia in a couple buckets. So sick, not sick. Obviously, those two categories are going to determine the acuity with which I approach. This patient clearly is very sick. So, you know, right off the bat, I'm getting the crash cart in the room. I'm putting the pads on the patient and getting set up for whatever management is necessary acutely. The second question I always ask myself is, you know, the two big categories of wide complex tachycardia are ventricular tachycardias and supraventricular tachycardias with aberrancy, right? And so that supraventricular tachycardia could be anything from atrial tach to sinus tach to AFib to aflutter. And the aberrancy could be from anything, because they have a pacemaker, or they have a baseline bundle branch block, to metabolic derangements. And hyperkalemia, I think, is super high on our differential here, knowing what we know about this patient. So 100% without question, I would be pushing calcium in this patient while I'm setting up to do everything else. Now, there's some things about the wide complex tachycardia you can look at that can help with that. You know, one thing is that it's a fairly slow wide complex tach. So, you know, typically ventricular tachycardia is really fast, you know, approaching 200 beats per minute or higher. This person's heart rate's in the 1 teens. You can have slow VTach as well, but it should trigger you to think about other things. And then often these hyperkalemic wide complex rhythms are wider than a typical ventricular tachycardia rhythm. And there's all sorts of ways you can kind of get into sorting out which it is and what's the most likely thing that's going on here. But the bottom line is you are better off pushing calcium, even if it's not hyperkalemia causing this. Calcium is probably not going to be harmful, and a lot of times it's helpful. It has inotropic effects and vasopressor effects. We always talk about in the critical care world, calcium is God's pressor. So that's what I'm often pushing, even when people are on high dose pressors already. So I would absolutely be given that. I don't know if we want to get into calcium chloride versus gluconate. Ultimately, whatever you have in your hand is probably the best thing. Is kind of the short answer. Now, to your other point about
and just as far as briefly on the chloride versus gluconate, I always think of chloride about 3 times the potency of the gluconate. But again, if you only have gluconate, I mean, you can certainly give that, see what happens, or give 3 doses, right? So certainly the calcium is the way to go. And just one other thing to emphasize what you had said, and just I'm sure that you were thinking these too, but like, first of all, we have a good reason for her to be hypokalemic because she missed dialysis. And this rate, like you're saying, and I know you just said it, but I'm just sort of broken record alert, emphasizing a little bit, but the rate doesn't really go along with VTAC. And so even if it is VTAC, calcium's not going to hurt anything. So, I'm not saying it's easy once you get the labs back, but certainly this is a clinical call that we're making at the bedside. And to me, it feels like that's the best part of medicine, right? I mean, I like testing and, even bedside ultrasound, like all those things, right? But, being able to have just us and the patient, their symptoms, and to do some intervention, even something simple like calcium could certainly save a life. All right, sorry, go ahead with your second point there.
Yeah, and there's a characteristic look to these rhythms too. I've had plenty of times where I know nothing about the patient. I'm sitting there at my desk signing EKGs and I see one pop up and I go, that's hyperkalemia. Let's go look at this patient. So yeah, 100% agree. And the calcium chloride versus gluconate, they're both effective. I think the guidelines that are out there, the Cochrane view that was done, that recommended ultimately giving chloride if you have it, just because it's that much more concentrated, less volume, you get it in faster. More issues with possible extravasation and local cutaneous reactions if you use chloride through a peripheral IV. So that's a consideration too. But what I was going to say is about the other parts of treating hyperkalemia and doing those empirically before any labs are back. I typically hold off on that. The calcium is the most important thing. As soon as we get that blood IV access, we're going to be sending a critical battery to get us a little bit of information to guide things. And the last thing you want to do is give this patient a big bolus of insulin to cause intercellular shift and temporize their potassium levels when the glucose is 26 or whatever. So I typically hold off on those measures until I have labs, but I absolutely go ahead and push the calcium right away.
Perfect. Okay, so let's keep moving things here because we have decision point A plus also B and C. So Mike Winters, obviously this is like a 2-hour answer that you could give us on this, but we gave the calcium. The patient's hypotensive certainly could be because of this, complex tachycardia and the hyperkalemia. But what else are you doing? I would guess, IV fluids and how much. Would you sort of maybe start with some blood, just for example, or would you go to vasopressors? What are you doing with this hypotension based on what you know at this time?
Great question, Mike. So I think several things at once. And I think all of us are going to start some IV fluids in this profound degree of hypotension. Do we consider sepsis, hypotension, tachycardia, altered mental status? Sure. Would they eventually get empiric antibiotics? Probably. But I think starting off with some amount of fluid, am I going to write for 30 mLs per kilogram? I don't think so, but starting with fluids. And over the years, I have moved to much earlier initiation of vasopressor therapy, especially with such profoundly low mean arterial pressures. I will often start things concomitantly because I'd like to get that mean arterial perfusion pressure improving perfusion to vital organs while we start to search and get a better idea of what the underlying etiology is. So starting fluids, starting vasopressors, norepi is going to be the drug of first choice in the majority of cases. If it's through the IO, if it's through the peripheral IV, absolutely. But I am certainly utilizing vasopressors. Now,
Okay.
to that,
Oh, go ahead. Go ahead.
I was going to say to that end, push dose pressors, bolus dose pressors is quite common now in emergency medicine in resuscitation. I will be honest, full disclosure, I tend not to use bolus dose pressors in my practice. It's out there. A lot of folks do it, and yes, when you look at the literature on bolus dose or push dose pressors, it does augment your numbers and improve the mean arterial pressure. My preference is to initiate continuous infusions, and I have, to that end, I've got ED pharmacists round the clock in the emergency department that are on it with us in the middle of the resuscitation. So I have the opportunity and the resources to really quickly get an infusion started. So that is why fluids, vasopressor infusion, because of my practice environment. Now, lastly, from a differential standpoint, I think we're going to be pulling the ultrasound in fairly quickly. While we are concomitantly resuscitating, we are going to use whatever protocol you like with respect to ultrasound. Rush is the most common, but looking and answering those three big questions: is it a pump problem, a tank problem, is it a pipe problem? And then within those three big buckets or categories, you're asking three well-defined questions. With the heart, is there tamponade? What's the overall LVEF? Are there signs of right heart strain to where I need to think of massive PE? Is the tank leaking? Are they bleeding anywhere? Is the tank compromised with a pneumothorax? And then looking for other signs of, is the tank empty with respect to volume assessment? Yes, there are drawbacks to utilization of ultrasound for volume assessment in spontaneously breathing patients, but it provides us at least with some information, and then looking at the aorta. So concomitant fluids, pressors, and then really heavy utilization of ultrasound in this initial resuscitation.
Love it. Cody, we haven't heard from you for just a little bit here, but I wanted to just simply ask you this question. I know we had a couple of people were going to ask this question, but as far as the ultra level of consciousness, I mean, certainly the hypoglycemia, but say, for example, we push an AMPA D50 through our great IO line that we have, that we've all recommended, and the patient is still totally unresponsive. What are you thinking just for some other etiologies that we can consider as far as ultra consciousness in this patient?
Yeah, I think it kind of goes back to the anchoring bias that we were talking about. A lot of people, when somebody with end-stage kidney disease comes in to the emergency department or even on the floor and they see, okay, well, maybe this is a symptom of uremia. Somebody that's otherwise very well dialyzed, and even this patient who has missed one appointment for dialysis, uremia is fairly rare. Those people are pretty well taken care of in the outpatient setting. And I think most of us are leaning towards, in addition to the process of sepsis at this point, hyperkalemia, which is a much more acute process than a rise in BUN. Certainly one thing I would want to look at in this patient is what is their access? When was that placed? Are there any overlying skin changes that could be indicative of, is there a soft tissue process going on? Could this be a potential CLABC? That's something certainly that needs looked at for anybody that's coming in with vascular access.
Perfect. Okay, I'm going to jump us ahead. So what happens with our patient? Then we'll get to decision point B. We're going to move through the last couple ones a little bit more quickly. We'll definitely end right at 9 o'clock. So finger stick blood sugar is 27. She does get 2 amps of D50 through our fantastic nurses, are able to get a 20 gauge IV in the left forearm. But as we had predicted, Cody, no improvement in mental status, and they can't get a second IV line. The blood pressures rechecked, basically identical, 62 over palp at this point. 1 amp of cardiac epi is mixed at the bedside and 2 ml are administered. Now, we don't have to talk about like mixing up stuff at the bedside. I'm personally not a big fan, but anyway, that's what was done at this time. There wasn't a complication from it, but that's probably a subject for a different time. Systolic blood pressure is about the same, and as Mike Winters had sort of thought, norepi infusion is ordered. We don't really have specific orders as far as what kind of fluid bolus has been administered, but hopefully we've given some fluids too. So let's sort of jump right in here with Dan Martin, and I'm going to ask for just probably a like 10, 20-second answer on this one, but she's hypotensive. Say we are starting fluids, starting pressors. and we wanted to get a head CT because we're concerned about maybe other reasons for ultra consciousness, for example, a bleed or maybe even a stroke, right? Although again, she was found unresponsive in her bed, so there's not a systemic thrombolysis consideration. I mean, of course, but at any rate, do you have the patient leave the department for head CT, or you feel uncomfortable with that at this time based on her blood pressure?
I always remember the dogma that people go to radiology to die.
Yes.
So, so I don't want to be part of that. So I'm really trying to stabilize the patient. Now, I might feel differently if there was a blown pupil, evidence of trauma, and I realize this person needs to go to the OR and somehow there's an arrhythmia that has something to do with increased intracranial pressure. I mean, that may change my mind, but most of these mental status changes that are hypotensive, whether it's sepsis or whether it's some other cause, something that head CT is going to show you isn't going to help without a real focal exam or something more obvious. I think the patient needs a head CT, but I want them much more stable before I did that.
Right. And I have to say, in my own practice, I'm sending patients who are in the process of resuscitation if it would make some emergent difference. And if we could continue that resuscitation and the CT scanner, which is so close, and literally these days CTs are like a minute, right? That being said,
That's true.
this patient certainly with a pressure of 62 and, obviously being unresponsive, it's hard to imagine how a head CT is going to change our management of the patient at this time, because even if she has a bleed, no one's taking her to surgery until they get her resuscitated. So let me jump over to Mike Winters here. We'd already talked about the hyperkalemia and the white complex tachycardia. Mike, I just want to have you very briefly say we give an amp of calcium glucate and nothing changes. Do we stay with the calcium, give more? How does your sort of maximum that you're going to give calcium wise? And say we do get a response, when do you go ahead and repeat that calcium administration?
The short answer is, Mike, I'm going to give additional calcium, especially in this very sick patient, for all of the reasons from an EKG analysis that everyone here has gone through. I think Dr. Warlow from Lehigh Valley commented. It's this, with respect to the rate, how really wide complex this is. It's hyperkalemia. So I will give another amp of calcium gluconate, perhaps move to chloride, depending on what your resources are, what you have at hand. In terms of the timing of that, I don't know that I have any dedicated preference, maybe 5 to 10 minutes, but I'm not going to let this patient languish too long while we're aggressively resuscitating her.
Okay. I think we'll skip the next question and let's just sort of go around. We talked about that intubation with that hypotensive patient initially, but say now she has been given some amount of IV fluid, say she started on vasopressors, say her pressure, just for the sake of argument, goes up to 80. She's still unresponsive. Why don't we just sort of go around real briefly? And Mike, since you're already sort of unmuted, why don't we just start with you? When would you wait? Or I guess I could ask, would you intubate the patient in that scenario? And if not, what would you wait for before you intubated the patient?
Not yet, Mike. So I
Okay.
don't feel that she's resuscitated enough to where I feel
Got it.
comfortable doing RSI. You referenced Alan Hefner, who's a good friend at Carolina's. When we look at everything that's assessed, peri-intubation cardiac arrest, the predictors of that, there's really just a handful that routinely come up, whether it's the adult or pediatric literature: pre-intubation hypoxemia, pre-intubation hypotension, elevated shock index. You can also throw in older folks along with obesity and the lack of adequate pre-oxygenation, but she's still screaming poor perfusion, elevated. I don't know what the heart rate is with that number you just said, but she's likely got an elevated shock index along with still pre-intubation hypotension. She's still at super high risk for peri-intubation cardiac arrest. So I'm not intubating yet, especially because we're not given much in the way that there's airway compromise, although we need to protect it, but there's not yet much airway compromise, not significant hypoxemia.
Right. I mean, it seems to me like the reason, and I know this is maybe me saying something bad, but this whole like protecting the airway thing, like I get it, and certainly important at times, but in this situation, right, the intubation could actually cause harm. versus a patient who's not vomiting and maybe who is handling secretions, etc., and has a SAT of 91% on only 4 liters nasal cannula. Greg, what is your thought on intubation? Then we'll move to our next decision point.
Yeah, I completely agree with you and Mike as well. She's not ready yet. We got to get that blood pressure up. The other thing I'd be waiting for here, honestly, is that critical battery test too. I want to see what her pH is doing. You know, my suspicion is that she does not have a robust respiratory compensation for the presumed underlying acidosis that she has here with the other metabolic derangements. Respiratory rate was 12, right? So thinking about what that pH is, I think about the 3 H's of predicting peri-intubation cardiac arrest, being hypoxemia, hypotension, and pH. So that's the other thing that you're going to want to try to optimize beforehand. And I completely agree. We have this idea of airway protection, but what are we protecting the airway from? We get so many ICU transfers of needs intubated for airway protection. I can sit there and look at a person who won't open their eyes at me all day before I kill them with an endotracheal tube, right? So you got to think about what the more urgent life threat is here, which, that respiratory rate may be part of her life threat. Maybe she's not responding to our vasopressors and everything because her pH is in the toilet because she's not breathing enough on top of her metabolic acidosis. And so maybe, she definitely is going to need an airway if she doesn't perk up with, the things that we're doing. But what can we do to optimize her first? We have all these mantras, GCS less than 8 intubate. You got to look as the expert in the room at what the risk and benefit of what you're doing is. And again, maybe as a critical care doctor, I'm a little bit more of a cowboy and I'm willing to watch some people who look really bad without doing that. I'm also willing to strap a BiPAP mask on a patient like this because, the concern is that they're going to vomit and aspirate. Well, you know what? I'm not leaving that bedside until this patient is stable and they have an endotracheal tube in. So if she vomits, bam, I take it off. But the BiPAP is really useful, to help optimize her respiratory compensation for the presumed acidosis. It's also going to give me some information about her minute ventilation that may be helpful in the process of intubating and setting the vent. It's also going to help with the pre-oxygenation. So those are just a couple of the things that I'd be thinking about doing before pushing induction meds that are very likely going to kill this person.
Gotcha. And Mike had mentioned our friend Alma Matu, who actually many years ago gave a lecture about, I think it was a salicylate overdose, and the patient was intubated and they weren't able to adequately respiratorily compensate for their low pH, and they arrested and died. And certainly that consideration is really important. So I'm glad we did spend some time on that. So you asked Greg about the labs, and they are now back. This is such an amazing expert panel. We appropriately and correctly predicted the hyperkalemia. She's 8.9. Greg, yes, pH is low, 6.8. And unfortunately, despite all of our best efforts, her blood pressure goes down. Now, Mike, you had mentioned the rush exam. So they show that the heart is hyperdynamic, the IVC midsize, not collapsing, aorta normal, no free fluid, and the lung, it's at the bottom of the screen here. So they do decide at this point to intubate the patient. They use ketamine and rocuronium. And let's just move to our next decision point. I think we're going to skip over the vent settings. We've already talked about the hemodialysis catheter. Let me, Cody, just bring you in real briefly as far as antibiotics. I know you mentioned possible skin changes over the dialysis catheter. At this point, say you are manning the ICU and you maybe come down to the ED because you know this patient's coming up. Would you recommend antibiotics at this point, knowing what we know about this patient, Cody?
Yes, I would at this point. We really don't know what other pathology was going on. There could be lung pathology. There could be an intra-abdominal infection. We really don't know. So I think it's very reasonable to start antibiotics.
Okay. Mike, I know we talked about the vent settings just briefly. I said we're going to skip over that, but can you just give us just a real quick, Mike Winters, on what vent settings you would use for this patient? This patient was intubated. Maybe you get there right after she was, so you weren't able to stave them off any longer. What vent settings would you recommend for this patient?
It's a great question, Mike. And I think as in general, many of us are familiar with lung protective settings. So we're utilizing lower tidal volumes to limit volume trauma, limit ventilator-induced lung injury. So lower tidal volumes, appropriate PEEP, appropriate FiO2, so not always keeping the patient indefinitely on 100% FiO2. and then monitoring plateau pressures with a general goal less than 30, depending on the patient population. Having said all that, this patient is profoundly acidotic, and this is one of the potential, if you want to use the term, clean kills from an intubation and ventilation standpoint. And so it's very important. Now, if I had just walked in the room and had no idea and I hadn't seen the patient and was resuscitating, it would be more challenging. But being there from the beginning, really getting an idea of what their minute ventilation was, quite honestly, and attempting to match that minute ventilation, because any lower levels of ventilatory support are going to worsen that, and she's right on 6.87, very precipitous decline, and then we're on to CPR, and then we can talk about cardiac arrest resuscitation. So I think the critical thing here, and they did it, they had a higher respiratory rate and slightly bumped up the tidal volume, but I think the key thing is to pay attention overall to the minute ventilation in this profoundly acidotic patient.
Yeah, David also in the chat says he had a salicylate overdose patient in the early 90s, intubated 18-year-old, coded and died, and learned a lot from that case, unfortunately the wrong way. And certainly I think all of us in our careers know this exact story. And unfortunately, it's not always clear that that was a salicylate overdose. So we know a lot more about ventilation at this time also. But David, thank you for sharing that. So Cody, let me just finish things up with one final question, and then we're going to have everyone just give a little summary here. Cody, emergent dialysis. So what would be the indications for that? And I'll flash up this mnemonic, the AEIOU mnemonic.
Yeah, absolutely. In my opinion, this person does need emergent dialysis. We're a bit backed into a corner of how are we going to deal with this hyperkalemia in such an unstable patient. We have some indications through the exam that there might be some element that she's having some volume overload, even though she does have hypotension. So, a lot of your therapies that you would give, Lasix, she probably doesn't have residual renal function. She's not going to be having any urine output. Albuterol can't really be used as monotherapy. I don't know this patient's sodium, and I don't know that they could tolerate the sodium load that would come with a sodium bicarb infusion, and it might make things a little bit worse from the volume status. So, in summary, yes, I do think this person needs emergent dialysis.
Okay, so why don't we do this? I'm just going to ask each of us to literally 30 seconds, maybe even 20 seconds, main thing that you'd like folks to take home from this case. Dan Martin, we will start with you. What are the big takeaway points you have, Dan?
Two things. One is this patient's so sick when they come in. The sooner you give antibiotics, the better. They could have been started probably a little earlier than they were started. Second thing is, remember that hyperkalemia, when you're giving calcium, it doesn't just stabilize the membrane. I hate that term. It actually restores the gap between the resting membrane potential and the threshold membrane potential. Think of it like that. It sounds a little more sophisticated. So I'll stop there.
Perfect. Greg, closing thoughts?
Oh, goodness, so many. All right, so IVO2 monitor.
You only get one, man.
ABCs, IVO2 monitor, glucose, Narcan. Any port in a storm as far as IV access. Use that dialysis catheter and apologize for it later after you save the patient's life. Resuscitate before you intubate. Calcium immediately before you get the potassium back if you have suspicion for hyperkalemia. And then with any metabolic acidosis, these are some of the most dangerous patients to intubate. This is not a set the vent and forget it. This is a put careful thought into how you're doing it, and minimizing apnea time and thoughtfully matching minute ventilation and end-tidal CO2 afterwards.
Kevin, I'm not sure I could ask any more from you by having you share both of those thoughts of syncopated in contrast and emergency patients use dialysis catheter. But if I could even think that you could give a third pearl that I would love, what is one big takeaway point you have?
Well, when the nephrologist gets that page from the ER, hypotensive, super tachycardic, it's going to be hard to start hemodialysis. So going to the ICU for continuous renal replacement therapy, which Cody and I were discussing even beforehand. That's exactly the modality of choice for this patient.
Awesome. Thank you so much. And Mike Winters, section editor, what are your big takeaway points you want to leave folks with?
So many great points already, not to overload anyone, but I would throw out, especially in this person with woefully inadequate MAPs, earlier initiation of vasopressors to bring that up as you initiate the resuscitation and work through your differential.
So what happened with this patient? The patient had vasopressin added to the other vasopressors. A-line was put in. She was put on Zosyn and vancomycin. She had CT scans of the head and abdomen, but came back fine. And as it turns out, her chest CT showed a multilobar pneumonia. And it's amazing how often the chest X-ray will be normal, and then the CT will show a multilobar pneumonia. But at any rate, she got admitted to the intensive care unit and actually did live through the interventions that we did in the emergency department. And I want to thank everyone here so much for your expertise and engagement with this, as well as, you know, agreeing that you can give a 20-second summary at the very end because we're running out of time. So I know that's not easy to do with so many great points that we could bring up, but what a fantastic panel we have, and I really appreciate it. For folks who did not see this, I tried to flash it on while we were giving some of our summary points. This is to claim CME credit. If for some reason you don't get that, you know, just email me, mweinstock@mweinstock.com, and we'll get that out to you. I want to let everyone know that on Thursday morning of this week, we have a mock trial, and I know we're talking about alma mater so much, and he was on our last mock trial we did at Adena as the emergency medicine defense expert. But this is up in Akron. We have four different emergency medicine residencies, and here is the live stream link at the bottom. I'll leave that up to there for a second, or if folks want to take a picture of it. But basically, mock trial October 5th, and that's the bit.ly link that you can use. And we have defense attorney, plaintiff attorney, we have expert witnesses from both sides. We have a urology expert, and then we have a resident volunteer defendant physician. This is an actual case with actual documentation. So it'll be really fun to watch this, not only from how the legal process goes, but also the medical parts. And then finally, for folks who would like to join us for our next critical care bounce back, this is on Monday, November 6th. There's a 48-year-old man with a beta blocker overdose. Colin Cade from Ohio State will be joining. Sean Nort, the EM toxicologist, USC, will be one of our panelists also. And we will see who else will agree to join us as panelists. But you can sign up very easily. The registration link is live just on the EM, so emergency medicine, bouncebacks.com website. I'll have this posted by tomorrow morning. So anyone that didn't see this who wants to, we'll put that up there. And everyone, thank you so much. I hope we were true to the 60 minutes that you gave us this evening on a Monday night in October, and look forward to seeing you all next time. Thanks again, everybody.